Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel at VillageMD. So excited to be here today and to introduce my special guest, Dr. Ezekiel Emanuel. Dr. Emanuel is Vice Provost at the University of Pennsylvania. You may know him from one of his books. He's a prolific writer, and his books are Prescription for the Future, which I highly recommend as a great guide to the American healthcare system. Reinventing American Healthcare is another one of his books. And most recently, he wrote Which Country Has the World's Best Healthcare? Dr. Emanuel is also on the VillageMD board, and most notably was instrumental in the development and passage of the Affordable Care Act, which is what he's here to talk to us about today. Dr. Emanuel, so glad to have you here. How are you?
Good to be here. Thank you, Wendy, for having me.
So great to have you. And as a lawyer who works in healthcare and is a student of regulatory change, it's so hard to keep track of everything with the Affordable Health Care Act. And it's in the news almost every day now. And already we're seeing lots of movement. So it's just a good time to kind of refresh our thinking about what it was to start with, which I know you were very involved with. So can you tell us what your involvement was and how you got involved with the Affordable Health Care Act?
So I was an academic, actually working at the NIH doing research, and I began working much more intensely on health policy beginning in 2005, 2006 with a series of ideas. And then when Obama got elected, he appointed Peter Orszag as the director of the Office of Management and Budget, which I like to say is one of the least known but most powerful offices in Washington because it controls the $4.5, $4.8 trillion federal budget. And he said, would you like to come on and advise as we're trying to do healthcare reform? And that's how I got into the Office of Management Budget. It's literally located, if you look at the White House straight on, there's a sort of very, very fancy building to the right called the Eisenhower Executive Office Building. And it's within the White House complex. And you just walk across the street to the White House. And my office was in that Executive Office Building.
Wow. So that was a big day. I mean, it's just a little job. Hey, can you help us change healthcare in America? So you then went about trying to architect and develop and create, probably with a big team.
I would say that there were probably, 20, 25 people between the White House and the senior ranks at HHS working on the Affordable Care Act. And inevitably, you're drawn into some of the big policy decisions, and then, people take the areas that they're very interested in. And then so, I was very interested in the alternative payment models that we were going to put in, the creation of CMMI, the Center for Medicare and Medicaid Innovation, CORI, the Patient-Centered Outcomes Research Institute. I was pushing internally, it didn't go anywhere, malpractice reform. That there are a number of areas, in addition, obviously, the subsidies for the exchanges, the construction of the exchanges. Some of your ideas get in, some of your ideas go by the wayside, some of your ideas get mutated and go into a bill. I also worked on some of the important nutrition and food aspects of that because I was also working with the White House chef, Sam Cass, on various food issues. And so I would say that it was a great privilege because it was wide ranging, but a large part of my focus were on those things, payment reform, trying to improve the healthcare system.
Well, that's the good stuff, right? Hard. But I mean, some of those have had such a long impact. And I think, when I think about the Affordable Health Care Act, one reason it's hard to think about what it is because it was so massive. And basically, not only did it create insurance exchanges and a mandate, but it seeks to improve healthcare as well.
I always joke with my students, how big was the Affordable Care Act?
Yeah.
And, a lot of people, it's 2,000 pages. And in point of fact, it's about 906 pages. A big fat Stephen King novel is the way I give students an analogy, and then everyone says, well, it's 90% coverage. But in fact, only 225 pages of that is about coverage, the expansion of Medicaid, the exchanges, the subsidies, the reforms to the health insurance marketplaces. And the rest of it is about a whole variety of things, everything from the Indian Health Service to CMMI, to taxes to pay for things, to workforce in trying to do things to increase the number of primary care doctors, to increase the number of nurses. So it is, as you say, Wendy, very wide ranging. There's a lot of focus on the coverage part, but that's, about a quarter, maybe a little more than a quarter of the bill.
Yeah, agreed. And we tried to sort of break it out. But the work that you're talking about, if we say there's a bucket of things that are just basically changing healthcare, those have been, I'd love to hear your thoughts, but some of those, like the CMMI, the Innovation Center, some of those have been very impactful and wide ranging, as you said. But I think it's almost hard to remember now that the big idea, and like, as you said, the one that makes a lot of news, one of the big ideas was this mandate, like the car insurance analogy, that you have to have insurance. And we don't even really talk about that or hear about that because the penalties, were eliminated.
Yes. So expanding coverage was very motivational. Before, the uninsured rate had ticked up to 15, 16, 17, 18%, and 50 million Americans, and bringing it down was a critical imperative. So if you imagine, how do you bring down healthcare uninsured rate, get everyone in? Well, first thing is you got to get people to say, look, you got to have health insurance. You can't opt out. And basically, part of the view is that's irresponsible. You are going to get sick. We know this. You might be hit by a bus. We know this. You might fall off a ladder. So rather than export those costs to everyone else and externalize them, we're going to make everyone have health insurance. Well, if you're going to make people have health insurance, and health insurance is extremely expensive, you have to provide subsidies to people. You have to give them some money. And then there's the question of, well, how do you get people health insurance? And, you're in the government. I'm in the Office of Management and Budget. One of the things you want to do is keep the cost of giving people health insurance low, so you're not spending a lot of money doing it. And that led us to a mix of, well, you got to provide a Medicaid for people because that's the cheapest way to get them insurance. But a lot of these people who are uninsured are working and middle class, and you got to give them a what's often perceived to be a middle class equivalent. And that was the whole idea behind the exchanges. One of the advantages is different channels for different people. A big disadvantage of that, and I think it's become clearer and clearer and clearer, is we just have a super complex coverage system, orders of magnitude more complicated than any other country. So my last book is Which Country Has the World's Best Healthcare? And once you survey 10 other countries besides the United States, you just really appreciate how unbelievably complex the American system is. Every system is complex, but we're way more complex than everyone else. So we had Medicaid, we had Medicare, we had private employer-sponsored insurance, and then we'll put to the side the VA, TRICARE, and all the other small aspects. But even three pillars. And then we added on another pillar called the exchanges and the marketplaces. So we made it more complex. And, I have many regrets, but if I have one regret, that is actually one regret. Rather than simplifying, we made it a little more complex. But we expanded Medicaid, and very big advantage, and one of the things that's happened over the decades since is a lot of people like Medicaid. We created these insurance exchanges. And then we also changed the insurance for those of us who had employer-sponsored insurance by doing a number of things. One, your children, more or less between the age of 21 and 26, it used to be that 21 insurance companies stopped covering them. Now it's 26. That's gotten 2 to 3 million young adults coverage. And good coverage because it's their parents' coverage.
Big change.
And it's one of the more popular parts of the bill. We got rid of pre-existing conditions. You couldn't charge differently for people with pre-existing conditions. That is probably the single most popular idea. Look, if I get cancer, I shouldn't have insurance that costs $50,000. So that's really important. We got rid of annual limits. Used to be lots of health insurance plans said, we're going to cover you up to $250,000 or whatever per year, and you have a lifetime limit of $1 million. Given some of the more recent therapies and their costs, like CAR T therapy for curing cancer, that can run hundreds, $500,000, $600,000. We got rid of those limits. in the insurance market. We made every insurance has to cover 10 essential benefits, everything from the usual, hospital care and physician office care to mental health and substance abuse care, to eyeglasses and hearing for children, to pregnancy and delivery, to, emergency room care.
The core basics, so there'd be apples to apples comparisons. I think that had to happen. So important.
Yes, exactly. So I think all of those were part of this coverage package and expanding coverage. And the upshot has been, I would emphasize, two things. We got about 20 million people coverage, 22 million. Since Trump took office, it's gone up every year.
Has it gone up? I was trying to find data on that, and I was wondering about that.
The uninsured rate has gone up every year under Trump for a variety of reasons. One is they dramatically constrained enrollment in the exchanges by cutting in half the open enrollment period, by reducing the advertising education. It's not the easiest thing. It's become easier, but it's still not easy
to access it and understand it and know what it is.
And, one of its problems, in my humble opinion, is it's not run like an e-commerce business. Basically, you're trying to sell insurance, and yet it's not run like an e-commerce business. The advertising, the way the websites are presented, the way the options are presented is not the way Google would do it, or Zappos would do it, or REI would do it. And I think now you know where I shop. And I think it has to become better. All of us have experienced, some websites are, like Amazon or REI are really simple to use, really fantastic. Some are really clunky, and it's like, I don't want to ever buy from this merchant.
Halfway,
Exactly. And it has to get more like the former and less like the latter. But in any case, that's the issue. The second thing that's really happened is now, we're heavy into diversity, inclusion, and equity, and the coverage gap that existed between whites and Blacks, whites, and Latinx have gone way down. They've not gone away, but they've gone way down because of the Affordable Care Act. So the difference in the number of uninsured people, or the percent of the population uninsured, has actually narrowed between whites and other minority groups. And that's been a really good, positive benefit. Now, it would be even narrower if the states that did not expand Medicaid expanded Medicaid, because they have very large proportion. They have 40% of the African-American community, I think, living in those states: Florida, Georgia, Texas, North Carolina.
Was the state option of expansion, my impression is that was not originally part of it, but that was a court holding later that there was an optionality for states. So then that led to such a disparity.
You're totally right. So the idea was we would expand Medicaid and we would make it so appealing to states that they would all jump on, and they would be forced to jump on. So the original structure in the Affordable Care Act is, look, we're going to expand it. We're going to cover 100% for a few years, and then the amount that the federal government pays for the expansion is going to go down to 90%. Still a great deal, because the more people you get covered, the less free care that states have to subsidize, is the decrease in state employee premiums because they're not paying for cross-subsidizing care for the uninsured. So analyses after analyses show that it's a financial win for all states. It actually decreases their financial burden if you expand Medicaid. It also turns out to be very good, especially for hospitals, but also for doctors. But these states have been recalcitrant. And the reason that, and by the way, let me clarify. If you didn't expand Medicaid, then all your Medicaid dollars would go away for the expansion, but also for traditional Medicaid. That was the threat.
Medicaid is a state and federal mixed blend of funding. There's conditions placed on states in order to get the federal funding. And so what you're saying is, if you opt out, then you don't get the federal matching of any kind.
Of any kind. And Medicaid's a program that has evolved over time. And so states are asked to do more or change what they're doing, since it was passed in 1965. But the court rule, and by the way, this idea that the federal government, we're going to withhold money if you don't adopt this plan. You don't have to adopt the plan, but you don't get this money. That had been upheld by the Supreme Court, most famously in a case involving drunk driving. You don't get money from the Highway Trust Fund to build highways if you don't raise your drinking age to 21 and create a uniform standard, a minimum standard of when someone's drunk. And that was upheld by the Supreme Court. So we thought, everyone thought, it wasn't just the Obama people, conservatives thought, this is going to be constitutional because the federal government can give you and withhold money. So the court ruled, no. The federal government can't withhold the old Medicaid money. It can only withhold the money for the expansion. And the reasoning, I have to say, is tortured. They said, look, it's too big a amount of money for states because it's often between a quarter and a third of state budgets, the federal contribution to Medicaid. It's really coercive. And by the way, the expansion is a new Medicaid, not the old traditional Medicaid, and you can't mix the two. That's pretty tortured logic for a whole series of reasons, but that's what's happened. And what it did is it allowed states like Texas, like Florida and Georgia to opt out for ideological reasons. As I meant, if they were following their interest, if they were following their pocketbook, they would enroll because it's actually financially better.
But it just became so political, right? It just became
impossible.
And we've got a slide here that shows, I got this from the Kaiser Family Foundation, I think, that kind of shows who's in, who's out.
One of the things to note here is that in some states like Idaho, Utah, and Nebraska, deep red states, deep red states, Medicaid has been expanded by putting it on the state ballot for a referendum by the voters. And even in very red states, voters want the expansion of Medicaid. Wow. And so it's an interesting political dynamic. If you actually put these things to a vote by the population, they actually want this. That's how you end up with places like Idaho and Utah adopting Medicaid.
It's interesting. And it's my understanding from just looking into this a little recently is this Medicaid expansion alone, like added coverage to like millions and millions of people.
Tens of millions. Yeah. More than 10 million people. Right. It's been bigger than the exchanges.
Yeah. I was surprised. I didn't know that. So what was it like then? Obviously you gave so much to getting this passed. I want to talk in a minute about the really juicy part, which is the change of healthcare. But then to have a new administration come in, this became, as you said, so political. And we sort of tried to think about like how it started, how it's going. And a lot of the things you just sort of peeled back. Like the very first thing was the mandate. So the penalty was zero. And it just created a domino effect, right?
Yes. So the administration in the tax reform, the Trump administration included in the tax reform, a repeal of the mandate. So basically, if you don't have health insurance, you used to have to pay a penalty on your taxes, and they got rid of the financial penalty for not having health insurance. And it turns out it made almost no difference. That has not been one of the reasons that the number of people without insurance has gone up. It tells you, first of all, that the people do want insurance, and the two big barriers to our insurance are the complexity of getting it, navigating Medicaid, navigating the exchanges, maybe navigating your employer-sponsored insurance, and affordability, right? You might want to get insurance, but you view the price as unaffordable, whatever it is, or the product, given how much you have to pay, then you add on the deductibles, just not worth it. And that really has been a big difference. So I want to make a plug here, Wendy, two things. So when Trump got elected, between his election and his inauguration, he called me, and I tried to do two things. One was to get him to say, look, you shouldn't repeal without a replacement. So if the Republicans want to repeal the ACA, they shouldn't just repeal it. They have to have a replacement.
Yes.
They always said, we've got to repeal and replace. I said, put the replace on the table. No repeal without a replace. Now, I got him to tweet that, and that stalled out the Republican rush, like in January, that they would repeal the ACA but not have a replacement. There's a good rendition of the story behind that in a new book that just came out called The 10-Year War by Jonathan Cohen of the Huffington Post.
Very good to know. I would love to pick up a copy of that. That's a fascinating story.
And it has some very nice vignettes of yours truly and my talking to Trump. That you will find amusing. Everyone who's read the book, from the editors to the critics, said this is like one of the most memorable scenes in the book. But then I also tried to get him, look, there are areas of bipartisan agreement like drug price controls, and you should focus on that. But you can, as you can see, in his 4 years, he never focused on it. Every time an election came up, he said, "Oh, we're going to do drug pricing," but never followed through.
I mean, we heard a lot about it, but was there a meaningful change to that?
Yeah, he didn't do anything. So,
right.
Part of what I really emphasized when I was in the White House pushing on the Affordable Care Act was the need for payment reform, the need to incentivize doctors and hospitals to change, to increase the value of what they were doing, try to get out some of the inefficiency, try to get rid of the unnecessary care, try to improve the quality of what they're doing, whether it's, controlling blood pressure, controlling diabetes. Yeah. I was a big believer in 2009, 2010 in bundled payments. I got something in the bill on bundled payments that we had to have five demonstration projects, but my original proposal, which was heavily resisted by CMS, is we should mandate that by 2015 we have 5 procedures or diagnoses that were being or conditions that were being paid under bundled payment.
What he's talking about is a bundle for an episode of care, not like today, if you have a hip replacement, you get your surgery, then you maybe go to rehab, then you maybe go to home health care or whatever. This would bundle all of that across the spectrum of care for that episode of care.
Right.
There were some pilots, I think ortho was one.
Cardiac surgery.
Yeah.
In the fee-for-service world, we pay the anesthesiologist, the orthopedist, the hospital, as you mentioned, the home healthcare agency, the rehab hospital, all separate bills. And by bundling it, you say, we're paying one price. We're not taking the carburetor and paying the carburetor separate from the brake, separate from the transmission, separate from the chassis. We're paying for the car. We're paying the whole hip replacement, no matter who's doing it.
The impact of that is so significant because it requires those providers to work together in a way that's so meaningful to care.
And it also incentivizes them. All right, what's inefficient here?
Yes.
Could we bring down the prices of some of those things, like the price of the actual hip prostheses? Could we shift care out of SNFs and post-acute care hospitals more into the home for rehab? If some patient says, well, there's some redness around my scar, rather than rushing them to the emergency room to take a look, sending a nurse to the house to look, and if it's cellulitis, start them on antibiotics and see if it resolves. So lots of changes in practice, as you point out. It really focuses on efficiency, and in many, many cases, and the federal government ran various demonstration projects on this. And, it definitely saves money with no loss in quality and maybe even a slight improvement in quality. So that was a big push that I can say, it wouldn't have happened had I not been there.
Yeah.
And I, very proud of. ACOs are another big example. It's in the bill, the necessity for CMS to adopt an ACO program and the various flavors of the programs, whether it's a MSSP or the advanced payment models. Those are developed by CMS, the Center for Medicare and Medicaid Services, but the need to do that was driven because of the law in the Affordable Care Act.
Yes, I see that. And one of the nice things about it is it sort of created a framework for evolution, like a longer, that's not, especially in healthcare policy, is when we make policy. You see this in some like states that do medical marijuana laws and things, and they put a lot of real clinical things in the law, and then it doesn't allow for evolution, and it gets very rigid, and it's so political, then it's hard to change. So this is like allowed change to grow and evolve and foster.
Correct.
I think this was a big topic in one of your books. It was the prescribing healthcare.
Yeah. And prescription for the future.
Prescription for the future. So much detail. I would really recommend that to our listeners. Is really, the thinking behind some of this, and it was the best really explanation of a lot of it. I've got a copy when I started at Village, and I read the whole thing and really
referred
to it frequently.
Thank you.
So as we said, a lot of things were rolled back. You mentioned that we talked about the mandate. Some of the funding for payers has been obviously controversial. There was a change more recently in Medicaid that allows states to require work,
That's going away under Biden. Yeah.
Yes. And I think he's already maybe through an executive order.
Correct. So the easiest things for the Biden administration to do we're rolling back the changes Trump did in terms of shortening the time in the exchanges.
Yeah.
We're going to add more money to advertising. This work requirement that the Trump administration allow the states to impose on Medicaid. first of all, it's been struck down by a number of courts because they said, look, work requirements are not relevant to the bill. The bill was to expand health coverage. They're not a way of expanding health coverage. Again, all the data suggests that actually when you impose work requirements, it reduces coverage. And so the court said that, but the Biden administration said, we're not going to approve any project or waiver, it's called a waiver, on Medicaid that includes a work requirement. So that's going to go
And
away.
that's very relevant to some VillageMD markets.
Absolutely.
I think Kentucky, Georgia, even I think Michigan.
Yes,
we've got a list
exactly.
of the states. Yeah.
So those are easy things for the Biden administration to do. In the American Rescue Plan, that is the $1.9 trillion COVID related, they're going to temporarily increase the subsidies in the exchanges and cap how much people have to pay for health insurance, which are two good
Those
moves.
subsidies go to the payers or do they go to the insureds?
They go to the payers. So if I buy a $10,000 health insurance plan and, I'm making $35,000, large portion of that health insurance plan will be subsidized. The premium will be subsidized by the government, and they are increasing the subsidies for people. If there's a problem, these subsidy increases are temporary. Whether they'll be made permanent, I think, is a big question. You don't have to raise taxes or cut spending to cover them in the interim because in response to the COVID emergency. These are budget rules in the United States for passing bills. On the other hand, if you're going to make them permanent, you'd have to find funds to support them. And that's going to be a lot harder to do. My own view is I think there's not going to be that much healthcare reform initiatives under the Biden administration. For one thing, I think, trying to get them through is hard political work, and, everyone's got an opinion. Someone's going to lose, and I don't think they're going to take that on. If you look at their initiatives, they're going to try to respond to COVID. And the second thing, once COVID's under control, towards the end of 2021, they're going to, look at infrastructure and climate change and really focus a humongous infrastructure bill on that. And then the last, I think, part of their major agenda is living wage legislation, which is, again, focusing in on three things. One is raising the minimum wage, and we're already deep into that. Second is going to be changing what's called the children's tax credit, what the federal government gives to couples or individuals who have a child. They're going to dramatically improve that. That's bipartisan because Senator Romney has a plan about it, which I think is a very good plan. And the third thing related to that is called the Earned Income Tax Credit.
Yes.
And that is if you work and you're not paid a lot of money, the government will top up the amount of money you get. And that has had a big effect. It's a very good bill for bringing people out of poverty. And I think they're going to try to strengthen that to apply it to more workers and make sure that it's easier for people who are eligible to get it. And so I think, my own view is those are the three big changes, and, redoing the healthcare system in one way or another, changing payment. If you look at the people who, the way they've staffed up, I just don't think they're going to be doing a lot of healthcare. The only thing that might make that prediction of mine wrong and might, sort of compel them to do more on changing how we pay for healthcare and some of the things is the fact that the Medicare Part A trust fund, that is the taxes that are collected from payroll that are used to pay the hospital bills. Part A covers hospital services. That trust fund will go in what's called insolvent, is predicted to be insolvent in 2024. That means that the government will be paying out more than they'll be taking in payroll taxes. And that is usually compels or forces action by Congress. And so I think that's where you're looking.
Well, that's really interesting. I mean, I think even though this is in the news all the time and has been for the last 4 years, as I go back and look across 4 years, and I sort of did an end of administration review of what happened, and a lot of the policies and things that happened really had a long arc. They really were not changes that Trump made. The most, I think, area that we saw a left turn from the Trump administration was in the Affordable Care Act. And I think one thing that I really learned is a lot can happen through just the executive branch. I mean, even if you don't have legislation, the power of the regulator is broad. And so they actually did do a lot. So I know that Biden administration has said strengthening the ACA is a priority. So we may see but what I think what you're telling us is we're not going to see a new paradigm. We're not going to see a new framework. We're going to live within this.
Yeah, I'm even skeptical that we're going to see a lot of fixing of the ACA, like with a public option or taking the Medicare age down to 60, things that the president ran on. I think actually it's going to be more modest than even that.
Okay. Got it. Well, that's really just great insight to have. And we're always trying to think about how this impacts our primary care providers and, people, just our workforce and our listeners, they just, are so really want to provide care to people. So people having coverage is important to them.
Yeah, it's important. Absolutely.
So one thing I wanted to just follow up on that you said that just intrigued me. I feel like I just love hearing you talk about this. It's just so fascinating. But you said you had other regrets. And I would just be interested to hear, if you don't mind, what those are.
Well, if you think about doctors and, since so much of the medical bill comes out of a doctor's pen for ordering, whether it's treatment or diagnostic tests or referrals, think about the fact that there's so many different payers that doctors experience. There's the Medicare Advantage plans, private insurance, and each one of the private insurance plans. I think that one of the things that would have made healthcare easier to incentivize change in physician behavior around those things, change in organizing the workflow of the office, is if we consolidated some of those funding streams. And I think instead of thinking about, exchanges added on to Medicaid, added on to Medicare Advantage, if we actually brought all of it together into one big exchange, right? So Medicare Advantage exchange plans and Medicaid, especially since so many states are Medicaid managed care, if you actually had one exchange and all of those people, now well over 110 million people, were buying insurance in one big exchange, and it was much more uniform, you would consolidate a lot more if you made the plans that had to be offered much more uniform. So one of the advantages of going to other countries is even countries like the Netherlands or Germany that have individual health insurance companies competing, they have much more uniformity in what services are offered, what the deductibles can be, what the copays can be, so that the benefit package, but also how physicians are paid, is much more uniform.
Yeah.
And that means that you can coordinate changes like this bundle is going to be not just a Medicare bundle, but also we're going to coordinate with United and the State Blue and other payers. That makes a big, big difference for doctors. It simplifies the incentive structure for them. It simplifies the different payment arrangements. I think that's something we didn't do enough of in the bill, and it would make changes and the willingness of doctors to change what they're doing to improve quality and lower costs much easier to effectuate. And I would say that's probably my biggest regret. Now, the CMMI can do it, but it creates some barrier. It's a little more awkward to do.
I see. So, Dr. Emanuel, thank you so much for joining us. This has just been really a highlight for us to have you describe all of this to us, and it's just been great to have you. So thank you.
Thank you, Wendy. And it's always been an honor to be on the board and to see VillageMD evolve and to, be at the cutting edge of trying to provide value-based care to our patients, which is so, so important.
Yes, it's a great time to be VillageMD. So thank you.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.